Recording in progress.
Isuri, are you ready with the history?
Yeah. Yes, sir. Shall I start?
No, we'll give another 2 minutes.
Okay.
7:05 will start.
Okay.
I'm Dr. Suranta Perra, Vice President of Sri Lanka Medical Association. First, I'd like to welcome all of you, all the medical students, final year and the other years who have joined for today's case-based discussion. And I'm very thankful to my colleague, Professor Randula, for joining with us. And he's expert in nephrotic syndrome. And then I'm very thankful to one of my registrars, Dr. Isuri, for taking the history. We have not helped, we have not communicated, we have just selected and let her take the history over half an hour. I think in your long case, you get 40 minutes for the history and 20 minutes for the discussion. Am I right, Randula?
Yes,
Randula?
yeah, 40 minutes for the history beginner and 20 minutes.
And, so the 20 minutes for the discussion. So what we felt is, if we can reduce it a little bit further, we felt better to give 7 to 8 minutes in this model. What we are modeling is the real scenario, and so the over 12 minutes we will have a discussion. We'll ask questions, and then the candidate will answer the questions. And over 2-3 minutes, Professor Andula and I will discuss what are the strengths and weaknesses, what could have been done differently. And at the end, over a few minutes, we will highlight key points for your knowledge, and then which will be useful for you. So it is 8 minutes plus 12 minutes for the case, altogether 20 minutes. Another 3 to 5 minutes for the give marks and the identify the strengths and weaknesses, justify why we give these marks, and the last 5 minutes to highlight relevant important ones. So the over to you, Isuri. Yeah, you may present the case.
Okay. Good afternoon, everyone. I'll be presenting a case on nephrotic syndrome. So first, I'll go through the history and examination. Master S is a 6 years and 3 months old baby from Malabe, and is the second born child with non-consanguineous healthy parents. This history was taken from the mother, who was educated up to advanced level, and Master S is already a diagnosed child with nephrotic syndrome. So this time presented again with a generalized body swelling for 10 days duration. It has started off from periorbital swelling, and then later on progressed to have scrotal swelling and abdominal distension, while the baby was already on prednisolone 40 milligrams every other day for 1 week duration. Before the onset of swelling, mother has noted several changes in the heat test, which was done daily at home. It is urine protein was nil for 3 weeks and then developed 1+ for 2 days, 2+ for 2 days, and 3+ for 2 days, and again increased to 4+ with the development of edema. So she has sought medical attention at that point and started on oral prednisolone 40 milligram daily. So before the onset of edema as well as the changes of the heat test, baby has had a mild upper respiratory symptoms with fever, febrile episode. But during this episode, no mother had not noticed red-colored urine and not known to have high blood pressure. Urine output has been maintaining normally, no history of headache or abdominal pain, no urinary symptoms as well. Over the course of this illness, no skin rashes, joint swelling or pain, or hair loss, excessive hair losses were noted by the mother. So this baby was diagnosed to have nephrotic syndrome 1 year back. Baby was apparently well 1 year back, where at 5 years and 3 months of age, had developed the first episode of nephrotic syndrome with generalized body swelling for 2 weeks duration. And urine protein was checked 2 weeks after the onset of these symptoms, and which was positive. So after seeking medical attention, she was admitted in the hospital and started on prednisolone, where baby responded with reduction of edema and resolution of urine protein test within 10 days of starting prednisolone. Again, baby developed the first relapse of nephrotic syndrome at 5 years and 8 months of age, while baby was off prednisolone for 1 week duration. The second relapse was noted at 5 years and 11 months, which was 3 months later, while the baby was in prednisolone 15 milligrams every other day for 1 week duration. At 6 years, again, the baby developed the third relapse, while baby was in prednisolone 30 milligrams every other day for 1 week duration. And the fourth relapse was about 1 month ago, while the baby was on prednisolone 50 milligrams every other day regime. So at the fourth relapse, baby was referred to pediatric nephrology follow-up. And all these relapses have responded to daily dose of prednisolone early. So initial baby was noted to have high serum cholesterol as well, but not started on any treatment. And mother was not known whether the baby underwent specialized blood investigations, and renal biopsy was still not done, but might be planned in the future. So baby was on and off prednisolone therapy, after starting which the appetite has increased significantly and has complained of on and off thigh pain. And as for the complications of long-term prednisolone therapy, babies are awaiting eye referral on the next day, the day which I've taken the history, and fasting blood sugar was done and it was normal. Apart from that, baby was on calcium, vitamin D as well, and levamisole was started 4 months ago, but not noted to have skin rashes or joint pain as for any complications. And full blood count, mother did not specifically know, but not known to be said any abnormality in the full blood count. BCG was not given actually because this baby was born in age, they have migrated back to Sri Lanka. JE was not also given. But other than that, all the other vaccines were age appropriately given until the 5th dose of DT at 5 years of age, and no extra EPI scheduled vaccines were given. Baby was breastfed as well as formula fed in the initial 6 months of life. Formula feeding was started because of poor weight gain, and then complementary feeding was started since 5 months of age. Currently, the baby is taking 3 main meals. It's 2 snacks. A main meal which usually consisted of 1 cup of rice, 2 vegetables, and a protein component, fish or meat. Mother was advised not to give added salts and give foods in low oil and low sugar components. This is the second born child, term baby, born at term with a birth weight of 2.9 kilograms, born in Italy. Antenatal history and postnatal history was uncomplicated. The preconceptional folic acid was actually not taken because it was not a planned pregnancy. So, non-consanguineous parents, where the mother is 39 years and father is 47 years of age. Elder brother is 11 years old. He is a healthy child. And no family history of renal diseases of hearing impairment according to the mother's knowledge. Development age appropriate, no significant allergies, and not undergone any surgeries. So mother is a housewife, father works at a restaurant in Italy, and they visit Italy once in a while. Currently, they live. The child lives with the mother and the brother at a rented house, where the rental is around 29,000 per month. Their monthly income is around 70,000. So they have come to Sri Lanka at 1 year of age because of brother's educational purposes. Once the mother is with the child, the other child is looked after by the maternal grandmother. The nearest hospital is Neville Fernando Hospital. Initially, mother used urine dipstick kit to check for urine protein, which contains about 100 strips, which cost around 1,000 rupees. But now she knows how to detect urine protein through the heat test. So examination wise, baby's weight is 24 kilos, height is 119 centimeters, and the body surface area is 0.8. Baby is not dysmorphic. There was no significant periorbital swelling, but bilateral ankle edema was there, no skin rashes. Abdomen was distended with smiling umbilicus, no hepatosplenomegaly, no bilateral bladder masses as well, and bladder was not palpable. There was horseshoe dullness and bilateral scrotal edema, but hernial orifices were normal. Cardiovascular system wise, peripheries were warm with capillary fill time less than 3 seconds, pulse rate around 96 with good volume, and blood pressure around 110 by 60, that is around 90th centile, and apex is not deviated, and dual rhythm with no murmurs. Respiratory system, the significant finding was bilateral lower zone dullness to percussion with reduced air entry. However, baby was not in desperate distress. Central nervous system examination findings were normal, and GABA sign was negative. So in conclusion, this 6 years and 3 months old child is having steroid sensitive nephrotic syndrome with frequent relapses, currently managing for the 5th relapse within 1 year of diagnosis.
Yeah. Thank you very much for that history and the examination. You have summarized it nicely. Randula, do you want to start the questioning?
Yeah, the last bit I actually missed because I accidentally log out there. And so if you don't mind, can you please let us know the problems that you have identified in this child?
The acute medical problem is having the 5th relapse of nephrotic syndrome, and on the background of steroid sensitive frequently relapsing nephrotic syndrome. And currently, actually, a baby has responded to the treatment with prednisolone. And other than that, in the chronic medical history wise, this baby was not given BCG because of the fact that baby was born in Italy. And as for the complications of prednisolone, long-term prednisolone therapy, baby has developed increased appetite, but other than that, no complications. Those are my problem lists.
Any psychosocial problems that you would like to look into this child?
Baby is actually developmentally age appropriate and very much engaged in school activities and not at all distressed, according to my observation. But maternal history, in the mother's history wise, mother is a bit concerned about having several recurrent relapses, as well as the fact that because of the long-term hospital admissions and other associated economic concerns, because their income is around 70,000, but nearly 1/3 of it has to be paid for the rent as the house, and they have other debts to be paid. So those are the psychosocial concerns. And of course, the father is away from them. Those are the psychosocial concerns I have identified.
Right. Okay. Now, in clinically now, you said that there are nephrotic syndrome. Start with the basic question, can be classified. There are three main classification in nephrotic syndrome. As a basic question, I think it would be very important for even to the medical students. I think we are in the audience, right? And what are the three main classification before we going into the management? Do you know how we broadly classified nephrotic syndrome, the three main categories or three main classification in nephrotic syndrome in childhood?
One is steroid responsive nephrotic syndrome, and then steroid dependent nephrotic syndrome, and steroid resistant nephrotic syndrome.
Is all these coming under the clinical classification of nephrotic syndrome according to the steroid sensitivity? There are two other classifications. Now, what you mentioned is correct, but it's coming under the clinical classification of nephrotic syndrome, which depend on the steroid sensitivity. And there are two other main classifications.
Pathophysiology-wise, primary as well as secondary, sir?
Primary and secondary is coming under etiological classification, right? There's another major classification called etiological classification, where we divide into primary and secondary nephrotic syndrome. There's another main classification. I think you are very much aware. That is a histopathological classification, no? Where you classified it into minimal change and non-minimal change. Therefore, nephrotic syndrome, there are three main classifications. I think it's a very basic. It can be classified according to the etiology, according to the histopathology, and the most importantly, according to the steroid sensitivity, which is a clinical classification. Right? Now, take your child in this patient and show me where this child in these three categorization.
Histopathology-wise, still the minimal change disease is a possibility. Because the atypical features were not noted in the history as well as in the examination. And then depending on the steroid response to steroid, it is steroid responsive, steroid dependent actually, frequently relapsing nephrotic syndrome. Still the most probable etiological factor is primary nephrotic syndrome. Because of the fact that other atypical features were not there, and in the history and examination couldn't find any other etiological factor.
Right. Going to a little bit details. Now, yes, you are correct. Now this child is coming under the etiological wise primary nephrotic syndrome. Primary nephrotic syndrome, again, you are having a subcategories, right? And subcategories starting with the congenital nephrotic syndrome, where children present less than 3 months of age. And then you have infantile nephrotic syndrome, where they present less than 1 year of age. Why we take this infantile nephrotic syndrome as a separate group? Due to its relationship with the genetic susceptibility, right? And then the idiopathic nephrotic syndrome, the main group coming under primary nephrotic syndrome, it consists around 80 to 85% of pediatric nephrotic syndrome. Therefore, etiology-wise, yes, it's a primary coming under idiopathic nephrotic syndrome. And then clinical classification, this child is coming under steroid sensitive nephrotic syndrome. Clinical classification, there are two main arms. Steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome. This child coming under steroid sensitive nephrotic syndrome, where there are again three subcategories: infrequent relapsing, frequent relapsing, and steroid dependent. Now this child is coming under steroid dependent nephrotic syndrome. And then even though we have not done renal biopsy in this child, we can predict, or we can say that this child probably be in a minimal change disease category, as you mentioned very correctly, because there are no atypical features in this child. At present, there are no atypical features. Right, that is the basic of categorization. Therefore, any child who is presenting with the features of nephrotic syndrome or relapse, in this background, we should be able to say where is this child in these three classifications, main classifications.
Yeah.
Suranta, anything that you can ask a few questions to start with? Yeah. I think Suranta, your mic is muted. Yeah.
Yeah. Is it right? After
Yes,
listening to what Randula said, what is your initial diagnosis for this child, nephrotic syndrome? Can you sum it up?
Yes, this is a steroid-dependent nephrotic syndrome with frequent relapses.
Frequent relapses. So why you said steroid dependent?
Because every time the child develops a relapse during the tailing of dose of prednisolone, so it is difficult to wean off the child from prednisolone therapy. And the reason to say frequent relapses is there are more than 4 relapses within 1 year duration, as well as more than 2 relapses during the first 6 months after diagnosis.
And you were talking about the mother is being trained for this training, testing the urine for protein.
Yes.
What will you how do you check the mother knows about it? What will you initially tell the mother if you want to educate the mother regarding this?
Initially, the proper method of testing for urine ward test, that we can demonstrate it first, and then ask the mother to do it by herself, and then again we can recheck her knowledge after a while. And then how to interpret the findings, there's a certain method. So if the protein is, she is asked to place a paper with black written, printed note. So if she can clearly see, read through it, then it is nil. And then there can be mild haziness, but still the print can be read, then it is 1+. And then 2+, the haziness is more, but she cannot be able, she may not be able to read it clearly, but black print can be seen. And 3+ is she cannot see at all, and 4+ is there's a precipitate as well. So that also we can initially demonstrate, and then recheck for the knowledge again.
Okay. If this child is, you were talking about renal biopsy. Why did you consider renal biopsy for this child?
One reason is having frequent, in this child, the most prominent reason should be having frequent relapses. Altogether 6 in the first year. But other than that, other indications for renal biopsy like persistent hypertension, persistent hematuria, or persistently low complement levels, and poor urine output with increasing renal functions, or then other atypical findings like arthropathy, skin rashes were not seen in this child.
Okay. You were talking about the vaccination of this child.
Yes.
Has the child been given all the vaccine?
BCG vaccine was not given, as I mentioned, because baby was born in Italy. I checked in the CHDR as well. It was not mentioned so. But other than, and the JE vaccine was also not given at 1 year. And actually at 1 year, they have returned to Sri Lanka. Other than that, all the other vaccines are given age appropriately.
And when it comes to vaccines, if mother has request to get BCG vaccine, what will you tell?
Now the baby is 6 years. So there's actually no real indication to revaccinate the child with BCG. But if so, the baby has to undergo a MANTO test first. If the MANTO is negative, only the BCG can be given.
One important vaccine is like we have the immunization program. The other thing is the extended program of immunization. One other important vaccine you want to consider?
The pneumococcal vaccine should be considered in this child.
Any other?
Varicella vaccine, but I'm not sure whether it is indicated after 1 year of age.
Right, okay. And then if you want to give varicella vaccine, what will be the issue? Because on steroid, isn't it?
Yeah.
And during examination, you were talking about Gauer-sign. How important is Gauer-sign to talk about in this particular case?
Because baby was on long-term prednisolone therapy, and mother gave a clue that baby is on and off complaining of thigh pain. So to exclude proximal myopathy, steroid-induced proximal myopathy, I checked for Gauer signs.
That okay. Anything you want to ask, Ranjan?
Yeah. Now, if I say I am not for a renal biopsy in this child, can you justify, or can you? What do you think about that statement?
At the moment, the specific indications that we look for before going into a renal biopsy are not seen in this child. But given the clinical picture, having frequent relapses and steroid dependency, I think there won't be any added harm in going towards a renal biopsy in this child.
Yeah, actually, just speaking, if you look at the indication for the renal biopsies in the children with nephrotic syndrome, in this child, there is no definite indication to do a renal biopsy at present, right? And I'm not agreed with your statement that it won't cause no harm. Renal biopsies are invasive procedures, right? And when you decided to do an invasive procedure, you should have a definite indication to do that, and that procedure should help the child, or would help the child when it comes to the management, right? Therefore, this child at present, there is no indication to do a renal biopsy. I emphasize on that because one of the participants has already asked about that, whether this child actually made the biopsy or not, right? And then steroid dependency. What is the definition of steroid dependent nephrotic syndrome?
Initially, the baby responds after starting 60 milligram per square meter per day prednisolone therapy. The baby responds within 20 days of treatment, but during the tailing off regime of prednisolone therapy, the baby develops a relapse.
Yeah, if you look at the definition, just for your information, dependency is defined as 2 consecutive relapses. The child develops 2 consecutive relapses while on steroids, so within 2 weeks of stopping the steroids, right? And that's the definition. The child develops 2 consecutive relapses while on steroids, so within 2 weeks of stopping steroids, right? That's why this child coming under steroid dependent nephrotic syndrome, right? And okay, now if this child presented to you as now this child presented with a relapse, right? How you identify a relapse? What is the definition, or what are there are 2 definitions. So when it comes to relapse, what are those definitions?
Baby having more than 3+ of urine proteinuria for 3 consecutive days. And that is that is during checking for the urine wart test, and then or else developing the clinical features of nephrotic syndrome with generalized swelling, albuminuria, and edema.
Yeah, if you look at briefly, or if you briefly stated, 3 consecutive days of 3 or more nephrotic range proteinuria, or any amount of proteinuria with edema, right? Sometimes proteinuria can be varied, but if a child is having edema, it means that child has already lost significant amount of albumin or protein. Therefore, both these 2 definitions can be used to define relapse, right? Okay, if this child presented to you with a relapse, right, and in your after your initial history taking an examination, what are the basics investigations you would like to order for further management or to decide on whether the child is having a relapse or not?
We can do urine full report. We can repeat the urine wart test and urine culture to exclude any underlying urinary tract infection precipitating this. And then we need to do urine protein to creatinine ratio in the first voided sample, and serum electrolytes and renal functions to get a baseline idea about the renal functions. And we can do the full blood count as well to get the baseline hematological parameters, because there can be hemoconcentration because of proteinuria and third place loss of fluids. And those are the basic investigations.
Yeah, if you look at, if you do a UFR, what are things you would like to look into in the UFR? The child with nephrotic syndrome?
Yeah, there can be red cells, which is indicative of microscopic hematuria, which can be a atypical feature on the background of nephrotic syndrome. And then pus cells, which may be more than 10 cells per cubic millimeter, which is indicative of ongoing urinary tract infection. Then the amount of albuminuria, the level of albuminuria, and then nitrates. Those are the things to be seen in the and then in the UFR, those are the things to be seen in the UFRs.
In the if you look, what about the cast?
Urine cellular cast may be again indicative of underlying urine infection, and other than that, I'm not quite sure about others.
Right. Okay. Right. And you said that you do basic investigation. I think the serum albumin level is also should be there, and I'm agreed you can do a baseline renal functions, especially if you are suspecting hypovolemia in the background. And then another important thing is to hematocrit, whether to see any, again, the feature of hypovolemia, the hematocrit can be increased in children with the low volumes, right? For those other urine culture, even people do routinely. If the child is asymptomatic, you don't need to do the urine culture as a routine investigation. And what if the child is symptomatic, or if you are suspecting you can do a urine culture also. But serum albumin level is so important, and also random cholesterol might give you a clue whether this is a nephrotic syndrome or even in the relapse, right? Urine protein creatinine ratio we don't do routinely because it's an expensive test. And if you have a 3+ or more apparent in the urine sample, I think it's not necessary to do the urine protein creatinine ratio at the beginning, right? Any other one that you want to ask any questions?
What I want to ask is moving to certain parts of the section history. You were talking about the levamisole.
Yes.
What are the side effects of levamisole?
Baby can develop skin rashes, and there can be certain changes of the full blood count with reduction of hematological parameters. And then they can develop joint swelling as well as joint pains, suggestive of arthropathies.
And about the diet, what advice you will give when the child is having this condition right now?
Especially one thing that we can advise is not to give foods with added salts. And then on and off, the baby has had increased serum cholesterol, so can be advised not to give added oil and excessive amount of oily foods. And because the baby is on prednisolone and can have some derangements of the glucose tolerance, can be advised to not to give excessive amounts of sugar, no added sugars.
And you have mentioned some of the social problems.
Yeah.
Can you highlight some of the social problems you have identified in this particular case?
One is some economic constraints on the background of around 70,000 of monthly income. The mother has to spend around 1/3 of them on the rent as the rent for the house, and the father is away from them. So the lack of psychosocial support for her is a problem. And then this child is now schooling, so because of frequent hospital admissions, the child misses school attendance. And those are the things.
So what are the expectations of the mother?
Mother's expectation is to go for a cure, not to have furthermore relapses, and go for remission in the disease process.
In the same line, if a mother asks a doctor, is it possible to cure this problem? Right. What is your answer?
Cure in the sense, most of my answer is most of the time the babies will go into remission or will not develop any further relapses, especially during the second decade of life. But up until that point, the baby can, as per the natural history, there can be recurrent relapses, which should be treated which should be treated properly. In that case, no residual damages will be seen. But very minimal amount of babies can have some atypical features with other derangements of the renal functions as such, but these things are not seen in this baby. So most probably, baby will go into a spontaneous remission in the coming years.
Did you speak to the child?
Yes.
What she think about the disease? Does she understand about it at least to a certain extent?
To a certain extent,
6.5 years old, no?
Yes, 6.5 years. To a certain extent, yes. He's a very, very active and very child who engages with others very well. So he knows about certain words in terms of the disease, but I didn't specifically ask from him about what he thinks about it and what is his perspective. But in terms of giving medications and maintaining compliance as such, there is not much of constraint seen in the child's side.
Yeah, I think especially when they are schooling, at least in grade 1, they can communicate. You must pay a little bit attention. And I think in the chat box also, Professor Mudyansi has posted this message to talk about IC, that is ideas, concerns, emotion, experience, and expectations. So those are very important to speak to them. You can take 1 or 2 minutes during the history taking to elaborate on that. I think, Randula, we are coming to the end of the discussion. Would you like to ask 1 or 2 questions and wrap it up?
Yeah, and now this child, now the child needs second line medication, right? Already on the omeprazole, right? And if I have decided that omeprazole is not good enough or may not going to help this child, any other second-line medications that you are aware of, which could be prescribed to this child?
I think there's a place for mycophenolate mofetil, sir. As the next line.
Any other medications? Mycophenolate mofetil is a known drug, and now we have a lot of experience. But before that, what was the drug that we usually considered mainly in children with steroid-dependent nephrotic syndrome? Before the availability of the mycophenolate mofetil?
Cyclophosphamide.
Yeah, it's oral cyclophosphamide, right? And therefore, yes, we can consider oral cyclophosphamide or mycophenolate mofetil as a second-line medication. When you start a second-line medication, it's better, even it's all better to give for about 6 months and then decide on whether we need to change it, right? And now it's almost there. I think Levesol seems like not helping this child much. Therefore, we need to think of another second-line medication to help this child. And there are few queries from the chat box. Suranta, we have a separate time to answer that question, so we need to discuss few things that they want to know. Your mic is muted. Yeah, please, sorry.
Yeah, Randula, without taking much time, if you can answer briefly each question, that would be fine.
Yeah,
or shall we come to the end? Shall we come to the end? We have come to the end of the discussion.
All right.
And then, Isuri, thank you very much.
Thank you
for presentation. Randula, what do you think your mark would be?
Yeah, sorry, Isuri is which is your level? Are you a second year registrar? Yeah.
Yes, second year registrar.
Second year registrar, right? Okay. And yeah, you have taken a good history, and I think the problem list and examination, there are enough space for improvement, and definitely the discussion part, there are a lot that you can learn with the time. Therefore, I put your range around 50 to 60 range in this history taking and examination. You definitely passed the case, but the marking may be in the 50 to 60 range. Yeah.
Thank you, sir.
I think from my point of view, Isuri, your history is you presented it very well. The flow was there. You covered all the components of the history, and then the examination was the components were there, and the presentation was clear. Summary was also clear. I think medical student level, if a medical student presented, mark would be around 65 plus, if I'm right. And then if you present this at the postgraduate level, 55 to 60 it lies. And then because I think the in postgraduate level, the history will have more complexity, and we can have a more deeper discussion. But at the medical student level, most important thing is to remember to get a good history and the mother and the child very well, because the examiners are maybe there. And then the second thing is the components should not be mixed, especially social history, diet, etc. And the examination also, because if it is not relevant, you can say cardiovascular or the respiratory system may be normal. And so that's the important thing. And those are the things I think if you do really well, it will be escalated to more deeper level, in-depth questioning. But to pass case with the nephrotic syndrome is not difficult. But the most important thing is to understand the basic. Why did you say nephrotic syndrome if it's the first case? And then if the relapsing case, why you say it's relapsing, or the thyroid sensitive and frequent, etc. And then the biopsy, what is the indication, especially the drug side effects. Those are very important things. Not to forget simple instruction to the mother and to handle the social history diagnosis also well. Over to you, Randula, anything you want to say?
Yeah, I think, you summarized well, Suranta. I think most important thing, especially when it comes to the medical students level. And to take home as a take-home message to me is, I want to tell everybody is the basics, right? Always when you get a child, see which in classification where this child is, the etiological, histopathological, and the clinical classification. If you find the answer for that, I think you can cover big part of the nephrotic syndrome. Right? That should be the take-home message. Thank you, Suranta.
Yeah, I think thank you very much, Randula, joining with us.